Day 3, Exponential Medicine 2018. Let's take a quick look at the summary of the lectures from today. The very first speaker was Salim Ismail, who is the co-founder of Singularity University, was a previous VP at Yahoo, a XPRIZE board member, and actually just an aside on the XPRIZE, the Clean Water Extraction Prize was just awarded last month, and the goal for that XPRIZE was to extract 2,000 liters from the atmosphere per day using renewable energy at a cost of less than 2 cents per liter. So anyway, that was a cool XPRIZE. But his presentation started off by showing the same cost curves in different industries. So the first one is looking at the cost of light over the last several centuries and how now the cost to actually produce light has essentially become negligible in most parts of the world. We next look at a graph of the cost of solar modules in watt dollars. And again, it's falling over time, following an exponential pattern. And we saw the other graphs showing the same cost curves with gene editing. And so the experience of Moore's law here is actually sometimes hard to imagine. And so he gave an example of his own personal experience driving his Tesla in June 2016 versus December 2017. And the first time he drove it, it drove itself by about 35% of the way between the two spots on his journey. And then the second time, it took the 30-hour journey and drove itself 80% of the way. And so this is an exponential jump, really, in the ability of self-driving cars. And this is a function of this increased ability to do computing. He discussed that many institutions around the world are being challenged. An interesting concept was in the area of education, we use what was called a push model, if you think from an industrial manufacturing perspective, and we probably want to teach more of a pull model for education. There was looking at the market cap and how long it takes to become a billion-dollar company. In the past, it used to take 20 years to create a billion-dollar marketplace, and now this can happen within a matter of months. And so the metabolism of the economy has increased. And when we introduce exponential technologies into industries, we see a period on their curve where you have a rapid deflationary effect. And so in this example of newspapers, you see that the advertising revenue kind of plummets off when internet advertising is introduced. We see a similar example here in the music industry where rapid fall off in CD purchase with the introduction of digital, but we've also seen these same deflationary effects with the previous versions, such as tape recorders, LPs, or 8-tracks. We can think about the fact that as we reduce the cost in some areas, this will actually lead to more discretionary funding. And an example he gave was that they were going to charge him $2,500, the electrician, to install a light bulb in his backyard. And so instead he went online and found it on Amazon, a motion-controlled solar-powered light for $9.99. And so this is the type of change in marketplaces that exponential companies and digital companies are able to have. Now, of course, it's very hard to think about exponential patterns. We're not very good at spotting them, and especially when the trend is very early on, when you're in that flat part of the exponential curve. It's very hard to spot a pattern there. Essentially, most people spot the technology when it's reaching the kick of the curve, and at that time they think the technology is a black swan, that it came out of nowhere, when in fact the reality is that we just didn't spot the doubling effect for many years. For instance, 3D printing in the last 5 years seems like it came out of nowhere, when in reality it's actually been a technology with over 35 years of development. Drone technology doubles every 9 months in its cost per price performance. And so this is essentially an exponential technology unfolding before our eyes, but we don't realize it. Another example is for the sensors for a driverless car. A decade ago would cost $200,000, and now it costs under $1,000 to retrofit the car. And if you look at it, one particular sensor, for instance, the LiDAR scanner. In 2012, that would cost $75,000, and in 2017, that costs $50. And part of the reason that we're able to drop the cost so rapidly on these technologies is that that LiDAR scanner has multiple technologies within it, and each of those technologies is undergoing its own exponential cost depression, which in the aggregate is causing a multiplier effect. And a few more interesting graphs that were presented. This one here is showing in the black line, which is almost a pure vertical, the historic growth of solar energy. And then we have these horizontal lines throughout different periods of time, which were expert predictions on how the experts predict that solar would grow. In fact, sometimes you even see these lines showing that it was going to get smaller and not grow. And what we see in the takeaway is that the experts were thinking linearly as far as the growth pattern for this industry, when the reality is that the growth pattern followed an exponential unfolding. Very similar graphs were seen apparently with cell phones and how experts predict that cell phones would be adopted. One graph which we see often here at exponential medicine conferences is how when something is digitized, it then drops the cost to zero. Then you get open source communities, the technologies intersect, you develop new products and services, and you disrupt existing businesses. This kind of comes out of the 60s that Peter Diamandis often talks about. One of the lines was that a company designed for success in the 20th century is doomed for failure in the 21st century. And there's some interesting work in the company EXO, that's EXOS, on trying to understand what makes an organization an exponential organization. We see that many of today's companies are entirely new to the space that they field. For instance, Airbnb is new to hotels, Tesla is new to automobile, and these companies all are experiencing 10 times performance over previous companies in those areas. It's really remarkable. Airbnb has 90 times more listings per employee. GitHub has 109 times more repositories per employee than other software companies. Tesla has 30 times more market cap per employee. And the question is, what is kind of the magic formula which allows these companies to operate in this exponential manner? And it was proposed that there may be 11 different features. The most important one is the MTP, the massive transformative purpose, which brings a company around it. And then in addition to this, there's other factors such as role of interfaces, dashboards, experimentation, autonomy, social engagement, leveraged assets, algorithms, community and crowding, staff on demand. And if people have more than 4 of these 10 or 11 characteristics, there's a much higher chance that they'll be a successful company. Just one other aside, the standard business model, as was pointed out, was a balance of demand and supply. The internet then dropped the cost of demand, the cost to acquire companies, and now the really successful companies are also figuring out how to drop the cost of supply, meaning that the unit cost to add another property to Airbnb is very minimal, and so you're able to rapidly grow your supply. So what they did here at EXO was they went and they ranked the Fortune 100 companies based off of these EXO characteristics. And they found that on average, they ranged from low as, in the 20s and 30s with an Expo score up into the 40s, 50s, and 60s. And what they then did is they compared people's Expo scores to their stock market performance and found that there was correlation. And then in addition, they went and they took the top 10 companies with the highest EXO scores compared to the bottom 10 companies with the lowest EXO scores in that Forbes 100 list. And what they found was that the top 100 companies had returns which were 3 times that of the S&P, and the bottom 10 companies were definitely the outliers, doing quite poorly. And so the next topic which was discussed was how to do innovation. And it was really advocated that innovation shouldn't be done in the mothership, meaning that a company's immune system is too powerful, and it's probably going to catabolize any innovation which tries to happen within it. And this is why, for instance, Google has done most of their work in innovation in separate companies outside of the main Google company. We've also seen this with Apple and with Amazon, where they take groups of team members, put them into a secret project, and separate them from the main company so that they can actually go and innovate. And we've seen this with other companies such as IKEA trying to get into vertical farming, Corona doing weed, and Nestle trying to do personalized diets in Japan based on people's DNA. All of these are examples of separate companies trying to be developed outside of that of the main company. This type of course on how to run exponential businesses has been offered by Salim, at different companies, and you can actually go now and purchase the book Exponential Transformation on Amazon for Kindle, and be able to take this 10-week program for your own company. It focuses on two things. One, it focuses on how to take a group of people and to create an external organization so that they can really try to work on innovative ideas. And then the second is how to take your existing internal organization and bring them up to speed on these more exponential concepts so that they are able to interact better with the spun-off companies when those products are developed. There's also a version of this program for the public sector called Fast Track. The next section was on neuroscience and neuromedicine, and it was really cool, the work which is being done. The very first person to speak was Divya Chander, who's a Singularity University Neuroscience chair, and she's an anesthesiologist who's had an interest in trying to read brains and understand and manipulate consciousness. And so by doing continuous EEG of patients in operations, you can understand what the wavelength patterns look like when people lose consciousness, when they're at the sweet spot during the operation, and as they wake up. In addition, you can create a drug dictionary of exactly what each drug pattern looks like under EEG when patients are under the drug. And so we have done research in trying to understand how to read brains, and then there's additional interest being done to try to how to write brains. Now, typically in the writing function, we've used things called deep brain stimulators, which are electrodes placed into the brain while the patient often is awake, as we've seen this example with the gentleman playing the violin as electrodes are placed. Now, the downside is that the technology is not perfect. There's a certain amount of spill off, and of course you have to have a hole in your skull. There's new fields trying to do deep brain stimulation using something called optogenetics, which essentially you take DNA from microbes that are sensitive to light, you inject that DNA into specific neurons, and then when those neurons are activated by light, it activates essentially the neuron to function. But the downside is you still require a fiber optic implant through the skull in order to be able to activate these new neuron cells with this microbe DNA, which is sensitive to light. We see here some examples of different optogenetic brain interfaces. Again, the downside being that you need still a way to get the light source into the skull. So what type of work is being done now so that you can have non-invasive abilities to write to brains? Well, one is using this concept called mechanotransduction, which is essentially the idea of pressure receptors. And so they've taken pressure receptors, placed these channels into the brains of roundworm, and then using low pressure ultrasound are able to control a roundworm as it moves by manipulating these pressure sensors using, as I say, low pressure ultrasound. Another example is through the use of nanoparticles that are able to take an infrared light, which can pass through the skull, and then these nanoparticles convert the infrared light to blue light, and then the blue light can modulate the neurons, which we were discussing previously. And the other example displayed was one from Lee Hochberg, who was one of the early godfathers in this field. And initially what they were doing was they were placing arrays of stimulators on the motor cortex so that people can control robotics using their thoughts, using the motor cortex of the brain. And now the newest work is to also place an array of electrodes into the somatosensory cortex, meaning that you can then feel the sensation of the robotic arm, which you're controlling with your motor context. And so, but again, the downside is that this requires an operation. And so people are trying to figure a hole in the brain. So there's work trying to come up with a way to do minimally invasive implantation of these types of devices by using sheets through the vascular structures going through the necks, as you would, for instance, for a carotid angiogram. Or the last work is also being done with something called piezo crystals, which are again trying to activate these crystals. And if you then attach this crystal to a nerve, you could potentially change the nerve's properties, turn it on and off by activating a piezo crystal using an external energy source. If we were to look at some new non-invasive ways to modulate the brain, we're using tools such as focused ultrasound, transcranial direct current stimulation, transcranial magnetic stimulation, and radio energy. And the big advantage with these is you don't even need to place anything into the brain to start with. We know that transcranial magnetic stimulation has been approved by the FDA for treatment of depression. There's other companies such as Insight Tech, which are trying to start clinical trials to treat amyloid plaques with Alzheimer's disease. And there's other ways which people are trying to clean up and mop up amyloid plaques, for instance, through combinations of flashing lights and pink noise heard by the ears, which then invoke a particular stimulation within the brain. There is thought from a February 2018 Nature paper that suggests that this will then reduce amyloid plaques. And if this can work for that, you can also do this on Parkinson's disease, migraine headaches. There's other papers showing that you can improve working memory through non-invasive external brain stimulation. And this improved working memory can have long-term benefits, such as at least up to 6 months from the trials. You can use non-invasive brain stimulation to improve sports performance. And there's multiple companies such as Halo, Hum, Thymic, all trying to do this same work. We see here just a graph trying to show improvement in memory through non-invasive brain stimulation. And, the thought was that perhaps we could use brain-to-brain interfaces, as was done in this first telepathy experiment in 2014, where someone sent the thoughts which were captured by an emitter subject on the receivers on their skull, and then transmitted to the receiver subject, which was a different patient. So, essentially being able to do telepathy. And now more recently in 2018, there's work being done trying to show that you can potentially link 3 people's thoughts in their heads together. We move on to Matteo Lee, who's the co-founder of Empatica. And they were initially trying to develop a tool for autism, but then they found that when one of their patients had a seizure, that the tool they were using actually registered that epileptic event quite profoundly. And so they then moved their product into the space of epilepsy. This is an important condition because we know that epilepsy and certain neurologic disease is the second cause of sudden and unexpected death in epilepsy. And so they have a product called Embrace. And what this is an FDA-approved watch, which can be worn and detect epileptic events and even be able to forecast before they happen. The advantage is that you can notify family and friends who may be nearby or caregivers and make it more safe for if the patient is about to have a seizure, potentially even prevent them. This is an example of some data from 1 year's worth of recordings. And as we see, approximately once a week, the device registered that the patient was going to have a seizure. We see here a patient's story on how valuable it was to the mother being able to come in and help reposition the patient and make sure that she's safe. We know that there are multiple triggers for seizures, and the thought is that we can measure these, quantify these, and bring these into the forecasts for a device such as Empatica, with the goal of being able to reduce the frequency and burden. They've also been doing studies with this device to try to do something called biofeedback. And so in this example, they had patients who had been reasonably drug resistant with epilepsy, and in one group they used this device to measure and to quantitate that they were using biofeedback therapy, and in fact they were able to, as you can see, reduce the number of epileptic events significantly. We'll move on to the next section now. This was by the co-founders of Muse, Ariel, Garten, and Graeme Moffet. And the word Neuro Technology has really been all over the news. Very popular now. Everyone's thinking about it. And the question really is, we know what the end goal is in neurotechnology, right? We want some sort of a seamless human-machine interface. But what they were particularly interested in was trying to understand the question, what technologies in this space are currently market-ready, and can we try to begin to use? They just started their presentation with this great picture here, which is actually the original wearable computing group from the MIT Media Lab back in 1993. And they still have the Media Lab a YouTube page, if I recall, where they publish their latest in machine-computer interface. Anyway, what ended up happening was they as part of trying to create an interface without the use of hands, eye tracking was used. And they found that as you were developing eye tracking technologies, that in order to use them and to use these different non-touch involved human-machine interfaces, you had to really clear your mind quite a lot. And in clearing your mind, you actually ended up creating a meditation tool, which is kind of how Muse got spun into being. And we know that there's lots of benefits of meditation. You actually get changes to the anatomic structure of the brain. When you look at the brains of people who are 50 years old who have been meditating, they appear 7.5 years younger than that of non-meditators. And so there seems to actually be probably a protective effect with meditation in the long run. We also know that meditation can cause an actual physiologic difference, even with work short as 4 weeks of practice. And all this is showing the incredible neuroplasticity of the brain and the benefits that this can have to one's health. Here's Muse 2.0, which was demoed at the conference. Again, now involving both mind recording as well as heart rate, breathing, and other body sensings. We move on to a really cool presentation from Meriva Jepsen, who's the CEO and founder of OpenWater. Now, when I first heard the proposition that she was going to replace an MRI machine with a wearable band, it sounded absolutely crazy and nuts. But Meriva Jepsen's a very smart lady. She's worked quite a lot in digital manufacturing, chip manufacturing, shipping customer electronics. She was part of the $100 laptop campaign years ago in Africa, and she's previously ran AR and VR at Oculus and Facebook. And here's essentially what she has proposed, and it actually, if they can pull it off, it would be amazing. But what they want to do is create a device which is the same cost as a cell phone and can produce scans for the same price as a phone call. The way that they're going to do this is by using infrared light, which we know can penetrate through the body. Then you end up getting the problem, though, is that when you penetrate infrared light through the body, if you placed a sensor on the opposite side of that limb, you have a lot of diffraction, diffusion, and scattering of light. But apparently, this has been worked out quite a lot in the field of holography from holograms, and that there are ways around it to create appropriate sensors that can reconstruct what had diffused and distorted the light. Then the third component is to create an ultrasonic scanning. And then you can use this tool to focus light, to focus sound, and to really begin to create new imaging. They created a prototype, and this is the one from this summer, where they were able to look at tissue to 0.5 millimeters resolution and then reconstruct images of what they thought that they were seeing in these phantoms, which were tissue phantoms. But one of the important things to realize is that blood is particularly easy to see, and in addition to that, blood is able to be differentiated into fresh blood versus older used blood, and these are going to respond differently to different wavelengths of light. And so because they can so easily manipulate the wavelengths of light in their models, it's actually quite easy to look at blood as well as whether it's fresh or old. And what they wanted to then do was to look to see what type of resolution they could achieve with their models. And so they first matched the resolution of fMRI, which is millimeter by millimeter. And then they went to see if they could get smaller. And they actually were able to get accuracy down to the level of a few microns, which has not just 1,000 times improvement over that of millimeters, but because you're looking at three-dimensional voxels, that's 1,000 by 1,000 by 1,000 times smaller in each dimension, you end up getting 1 billion times better resolution. These are big numbers. So here's an example of their lab prototype from last spring, which is quite a while ago. And they have since then gone on to create new prototypes. And this is apparently the size of the current prototype they're working on. As you can see, all the sensors, the optical detection ultrasound array, and fiber optic illumination have all been shrunk down to the size pretty much here of a rat body. They also claim to have made improvements to requiring now 10 times less light, 100 times smaller footprint, 100 times better image quality, and 100 times faster scanning speed. Where is this going? Well, there's a few really big benefits that this type of a technology could have. Well, the first is that 2/3 of the population does not have access to imaging, and so being able to do imaging through some sort of a low-cost, very easily portable, high-resolution band, which you almost apply to your body, is a very exciting prospect. The second thing is that most imaging tools are still too expensive. I mean, an MRI machine, you have to buy a whole room, and then you have to buy, hydrogen or helium gas. These things are cooled, liquid, and expensive magnets. The actual machine costs are prohibitive. And because these machines are too expensive, we aren't able to use them for cases where we would like to, because we know that the image quality is better. For instance, breast cancer screening uses mammography, which is an inferior technique compared to MRI. But we use mammography as first line for general screening because of the fact that MRI would be too expensive. In theory, if you could accomplish MRI level quality with this type of a low-cost devices she's trying to build, it would dramatically change the way we think about something like breast cancer screening. And then the third prospect of where this might be going is a little bit more out of the box. And this is on the thought about reading brains, right? This is the work which was done back in 2011, where they would play participants' Hollywood movie trailers, then watch and record what the fMRI brain mapping of their brain was as they watched the trailer. Then they went back afterwards, and then they would simply only replay then they would again play to participants the same, Hollywood movie trailers, but then this time they would just look at the recording from the fMRI readings of the patient's brains and be able to reproduce digitally and reconstruct what they think that person was watching with their eyes. We've seen other examples. I think this one was from Japan, where they had a patient sleep in an fMRI machine. You would then see some activity on the scans, wake up the patient, ask what they were dreaming about, and be able to develop a neural network and reconstruction this way. And the accuracy has gotten to the place now where with fMRI, you can actually have 80% accuracy over 1,000 images, and that means that there's a 0.1 random chance over 1,000 images being able to show patient an image and then retrieve afterwards what image you show them. So the thought is, of course, that this tool, which we've been discussing in this presentation, could potentially be used to monitor the brain at a particularly high resolution and be able to do so to produce massive data sets, and then with this potentially be able to read brains much better. And the presentation then also ended on the fact that the tool of focused ultrasound is undergoing rapid expansion. We see quite a number of uses here where there's already approved. They're either in pilot trials, pivotal trials, or they have FDA approval, or there's approval outside the US for different uses of focused ultrasound. And this is being used, as we can see from this paper. It's actually a great paper. You can pull up the full PDF. It's linked on the blog post. But the thought would be that this sensing band, which we've been discussing, could be a great companion tool to something like a technique like focused ultrasound. And so that's one of the other therapeutic uses for it. The next presentation was by Eric Leuthardt, and he's a neurosurgeon and the director of the Center of Innovation in Neuroscience and Technology. And very interesting work here thinking about computer-brain interfaces. So as we know in stroke, that one, trying to do rehab right away is very important. And then the second problem with stroke is that the area of the brain which controlled one's motor capabilities is knocked out. And the question is, how could you put a computer-brain interface now into a part of the brain which no longer functions? And so he really has tried to look into how we can fix broken brains. And the way that the technique that he's developed builds on something called Hebridean learning. But essentially what you do is one's brain still retains the intention or the desire to want to, let's say, move your right hand. And you can place a sensor on the brain to record the essentially EEG type wavelengths of the patient or the desire to move the right hand. And then you can reconstruct this pattern, create it as a signature that the patient wants to move their hand, and then have a physical robotic device on the right hand which moves the right hand when they want to. Then you can essentially feed back the thought that you would be able to retrain the left side of the brain, or so then you'd be able to retrain the part of the brain which is still active to be able to eventually execute these thoughts. So this is really trying to use neuroplasticity to retrain the patient's intact part of their brain to execute functions which previously were thought to be the exclusive domain of the other side of the brain. And so they showed a case example with a patient, Rick, who in using this hand glove sensor system has been able to regain incredible amounts of independence once again. The second part of the presentation looked at these concepts of depression and how we can heal brains with different types of mental health conditions. And what was proposed is that clinical depression is a dominance of the default mode network, meaning that we aren't cycling between the appropriate different mode networks which operate inside of the brain. And the treatment suggestion was we want to use something like vagal nerve stimulation, which increases brain plasticity. And then while the brain is more plastic, to use some sort of a tool to shape the brain, such as a digital therapeutic. And the combination of the two of these should help increase treatment results. Now, getting to the vagus nerve is a bit difficult, and there is, though, an external route to it, and that's through the transauricular branch in the ear. And so demonstrated was a stimulator which could be worn inside the ear, kind of like an Apple AirPod hearing tool. Or now, what we do then? What they would do then is that when the vagus nerve was being stimulated, you could apply different treatments based on the mental health condition. So for depression, you might use CBT. For PSD, you may use exposure therapy using virtual reality. And the suggestions are that the combination of the vagal stimulation plus the brain retraining would be able to have more rapid results and better results than either of these independently. The question, of course, where is this going? Well, the thought was that it's hard to imagine. And if you were in 1972 and you were trying to explain to someone who was playing Pong where Pong would be in 30 years, where it would be in 2002, the level of 3D gaming consoles, the person in 1972 would not believe you. And then similarly, if you went to the person in 2002 and told them about the virtual reality headsets which will be coming down the road, they probably wouldn't believe you. And so it's really hard to know what the future is going to look like because it often involves technologies which don't entirely exist. But if we wanted to try to play this game and understand what are these 1972 moments, what are our Pong moments which we're just stumbling upon, which are the first building blocks of future projects, we could look at the ability to control a device using an invasive cortical implant. The first time this was done was in 2004. And at that time, you could just play Pong. And then by 2011, you could actually control a robotic hand. We see in New England Journal of Medicine the ability that placing an electrode into the temporal lobe enhances memory. Where could this be in 30 years? We see that there is ability now not just to put encode information and decode information, but you could potentially share information between brains using this technique. And so there's some examples of real-time sharing of sensory motor information as published here in this paper. And then, could you potentially take this encoded information, store it for later, and then download it at a later time? Meaning, could you download memories? And there's a paper here from 2003 in Science discussing the ability to create false memories in the hippocampus. Where's that going to be in 30 years? And this was kind of ends the presentation here, but the interesting thing that Eric was talking about from his Center of Innovation in Neuroscience and Technology is that what they do often is hold something called an invention sessions, where they bring a lot of people into an invention session who often don't work together, who are from very, very different fields, and they talk about the problems that they're working on and what's new in the field of neurotechnology. And it's through these intervention jam sessions that they come up with a lot of the really big breakthroughs and innovations in their work. We went through then several inpatient innovators. Godfrey Nazareth, who has ALS, gave a passionate talk about the ability to continue to move forward and build new things. Matt Dieberg, who gave a talk on autoimmune diseases. Again, you're really trying to emphasize the fact that we need to understand what is triggering the immune system rather than simply layering on immune treatment suppression, so that we can ultimately try to reverse the underlying triggers. And we're seeing more and more small case studies which seem to be developing success in this area. And Meriva Filipova discussed that the Kubler-Ross change curve, which people go through when they have a life-altering event, shock, denial, anger, depression, problem-solving, then finally integration, involves anger and depression. And she didn't want that curve, so she tried to tell the story of how she developed a curve of shock, denial, and used curiosity as her means to fight fear, and it helped overcome and essentially have the large tumor beside her kidney eventually removed successfully with the help of the exponential medicine community. And now we get into Vinod Khoshla's session on the future of work and investing. I need some water for this one. This is going to be a long one. I always enjoy Vinod's healthcare discussions. One, because they're often quite confrontational, and two, for the most part, I generally pretty much agree with all of his predictions. His big thesis for a number of years now has been that 80% of the work that clinicians do today will be replaced with the machine. And he's been saying this for years, almost a decade. And the reality is that he started his talk today saying, I gave a version of this talk 3 years ago. Not a lot has changed, except things now are more certain and accelerating faster. Medicine gets better every decade, as he pointed out, but we're making incremental progress, and we're not really making the exponential progress we need. And the reason we need exponential progress is there's a lot of problems with the state of medicine today. So the first is that 50% of MDs are below average, or they're below the median. And he said that a physician actually got up at one of the conferences during his talks and challenged him on that statement. And he said, the person who challenged him was probably a below median physician. That, we know that over 40,000 patients in the US ICUs die from misdiagnosis annually, that doctors are surprisingly bad at reading lab results. There was a bone-chilling publication of the Washington Post back this October 2018 discussing really how bad doctors are. And we know we're bad, oh, wow, we're horrible at interpreting lab results. We should be better, given that it's one of the core things we do. And then we have the problems that human doctors have cognitive limitations and cognitive biases. And a number of journalistic articles were published elucidating references for these facts. We have other issues such as, 100 cases of diagnostic error involved internists, for instance, and in that study, cognitive factors played a role in 3/4 of those cases. And, cognitive factors influencing diagnostic error should be potentially something we should be able to eliminate. Premature closure was actually one of the most common causes for these errors. And other papers were presented showing that in high-risk diagnoses, that high information clinical findings often were present but somehow got ignored. Then he went on to describe a lot of the problems with our levels of evidence. The AHA makes 7,100 recommendations, of which only 19% have Class 1 guidance or Level A evidence, and 48% have Level C evidence, which is essentially the worst kind of evidence possible. Other papers, for instance, from obstetrics, were showing that 40 to 50% of all the recommended recommendations in those guidelines are based on expert opinion. And then to show the problem with expert opinion, there was an older paper from JAMA in 1990 where they took 58 experts and were asked to estimate the chance of an outcome in an important procedure. And we see that these 58 experts predicted the chance of that outcome somewhere between 0, 1%, 5%, 10%, 25%, 75%, 80%, and 100%. And so you literally had a full spectrum from 0 to 100% of different experts in predicting the same outcome from the same variables. And the idea that simply selecting a mean or an average of these results actually has a meaningful estimation of the truth seems quite ridiculous. So how do we get around these problems? Well, what's been proposed for a while is that healthcare will dramatically be changed through the introduction of machine into healthcare and the replacement and displacement of most of the work that physicians do. Now, one of the key things when understanding these timelines from Vinod Khosla is that pinpointing down the exact timelines on how many years and decades this is going to happen is very difficult, but we can imagine this process, one, undergoing multiple versions. For instance, you could look at different versions of the cell phone, technology evolving every 3 years, and then over the course of a decade or over 15 or 20 or 30 years, that type of cellular communications has gone under transformational experience. And so similarly, when thinking about doctor algorithm, you can imagine 7 generations, with each generation taking 3 years, going from 2017 to 2036. And at each of these generations, we're going to see marked improvements over the past. And so the thought is that almost nothing of what medical students learn today will actually be relevant in the way that medicine is practiced in 15 to 20 years' time. And, as Vinod said, when we talk about upscaling professionals, for instance, upscaling nurses to be as good as primary care physicians or better, everyone's very, very happy about this. But whenever we say that 80% of what doctors do is going to be replaced by machines, people get very angry. So it's just a optics and an impression thing on how people respond when they hear these types of predictions. But the big takeaway is that the way that we manage care and think about diagnosis will be definitely radically different. Several reasons. One, there's multiple innovations happening on multiple axes, all concurrently. And these are all slowly undergoing concurrent exponential kicks of the curve. Everything from AI to omics medicine, biomarkers, DNA editing, CRISPR, and then, of course, 3D printing and micro robotics. All these are essentially not used whatsoever right now in medicine, but most likely will become the core backbone for most of the way that care is delivered in the coming year. We already see this first version of Dr. AI unfolding. Vinod talked about that. He wrote 7 years ago a blog article in TechCrunch called "Do We Need Doctors or Algorithms?" And at that time, everyone laughed at essentially what he was proposing. He talked about algorithms doing a lot of the work of radiologists. And as he said, he was recently reread, and there's nothing he wants to change, because what was assumed to be impossible just 7 years ago with regards to computers reading imaging is now broadly accepted as happening. We also saw, that simply through the introduction of machine learning algorithms into Kaiser, that they were able to dramatically improve their stroke protocols and when they administer statins, and this reduced in a death rate by 40%. We've seen all the work earlier in other presentations with the work that Google AI is doing, which again was inconceivable not even 5 to 10 years ago, that you'd be able to essentially do advanced retinal imaging and diagnostics through the computer. And we're seeing a lot of other work, such as in the next 10 to 15 years, he predicts that most conversations between patients and healthcare will probably happen through an AI first. And the importance of this is that that AI function will be that of a triaging function. So triage is going to be the most important part of the first version of AI, which I entirely agree with is going to be that first feature. We'll probably see in the next 10 years the disaggregation of previous diagnostic criteria. For instance, this concept of something like diabetes as one single entity. Diabetes will go the way of dropsy. We don't use the term dropsy anymore, and instead we're going to differentiate and classify diseases not based on the symptoms, but on the actual underlying genomic and epigenomic causes. We'll also be able to use things such as the microbiome to predict, for instance, the development of diabetes before type 1 diabetes happens. Same thing with mental health. It's almost 100% certain that most of those care providers who provide mental health will probably be able to be replaced by an AI avatar. We've already seen in all the clinical trials using AI avatars that the results are actually better than in-person avatars, especially the work being done with PTSD and military. And so biotic assistants will probably be doing 80% of almost every major specialty in medicine sometime in the next 10 to 15 years, according to Vinod's very rough timeline predictions. As far as at-home diagnostics, we are seeing more and more emergence of being able to put a lab on a chip, and this essentially drops the price of being able to do thousands of biomarkers, all using small samples of blood. This again will change our understanding of holistic medicine, such as that work with Lee Hood has been doing as far as trying to understand network medicine. And of course, drug discovery will be done using probably more simulation rather than actual bench-side research. So these are all very practical, sort of not too far off at hand innovations for version 1 of this first generation of AI algorithm driven healthcare. He said that his goal would be in the next 10 to 15 years, every human would have access to primary level care through an AI physician. I actually think that timeline's a bit optimistic in some ways, and on the other hand, I think is quite plausible. It's entirely the right goal as far as how to scale healthcare globally, and I've been discussing that quite a lot as well. When you begin to look a lot further down the road, once you get maybe to version 5 of the algorithm, most of the imaging, testing, diagnostics will be handled through the machine rather than through a clinician. You'll probably have sometime in the next 15 to 25 years, Vinod's like to use the term, he said this quite a lot, about how data science will do more for medicine in this next coming quarter century than all of biological sciences combined, because of these exponential benefits that these types of tools that data science can bring. It's not to say that traditional healthcare through incremental improvements will stop happening. We'll still continue to build incremental improvements in research in traditional healthcare. But the big advantage and change will be that data science will allow us to make exponential jumps in the ability to provide care. And then the question is like, who should you actually hire to provide care directly to patients? If you're simply looking for the most number of mirror neurons and the most empathic person, you probably should go to USC Film School. And of course, the presentation ended with discussing the fact that he can't think of any industry in the last 30 years where the significant change in that organization came from within the existing ecosystem and existing organizations. They've all really been disrupted through external forces, and he predicts the exact same thing is going to happen within traditional medicine. When we think about, version 8, or as he said, version maybe in the year 2050, at that time, probably almost all of care will be directed and driven through data, through biomarkers, through imaging, and through quantitative physicals, that all subspecialists, oncology, cardiology, psychiatry, primary care will be able to be performed for the most part through AI. That this concept of symptom-based diagnosis will be, for the most part, completely bypassed and irrelevant to most of medical care. And then the big advantage is that this will actually make medicine affordable and accessible and much better quality. And we should also be able to predict a lot of the disease prior to its happens. Very end, you can check this on the blog post easier, but he posts his portfolio and the companies which are currently investing in. I've always been very interested in this selection of companies. All right, we're 2/3 of the way through. There's a few more presentations, some from Jennifer Radin and William Morris from Deloitte and from Cleveland Clinic, respectively, trying to understand what the future of work looks like. Then a session by Jay Parkinson, who's the founder of Sherpa, which is a company I've been watching, and it's been very interesting in this presentation to kind of understand more of the underlying reason for the founding of Sherpa and how it operates. And what they've really been focusing on is the discordance between the way that we've had exponential growth in the way that we communicate. There's many more tools that people use to communicate today than, for instance, 30 years ago. Cell phones, text message, email, chat rooms, chat threads. However, the ways that physicians can bill for their time has for the most part remained unchanged. And so the gap between the new ways which we communicate versus the old ways which physicians are remunerated for their time is the opportunity which Sherpa is moving into. The presentation starts with discussing a lot of the pitfalls and problems of video visits. Essentially what happened was that it was thought that, well, healthcare is going digital, we should make video visits possible. we'll make a video visits 10 minutes because that matches the 10 minutes office visit and makes it very easy to bill. We assume that doctors need to see patients and visually, and therefore video is the perfect model. And of course, if we're designing healthcare around doctors' schedule of being in the office from 8 to 9, or sorry, from 9 to 5, using a fee-for-service business model, this is exactly, the video visits fits into this very well. But the reality is that telehealth actually has kind of been a disaster over the years when you look at the objective numbers. We know that there's 3 million doctors' office visits per day in America. There's 300,000 urgent care visits per day. And so despite having 3 million doctors' office visits daily, there's only 3,000 phone or video visits per day. So it's just a small fraction of the total visits which are happening, despite this technology being around for quite a number of years and being affordable for quite a number of years. Now, the bigger player, of course, is Kaiser Permanente, who's often walked around talking about how half of their patient interactions are virtual. But when you really break down their numbers, and they published this in New England just in the last month in October, actually only 1.25% of their 12 million patients between 2015 and 2017 had a video visit, which essentially is practically none. I mean, most of it was through online prescription refills or maybe online scheduling appointments or patients viewing their results online. But when you actually look at how much of the virtual patient interactions at Kaiser was this magical platform of telemedicine and video medicine, pretty much non-contributory. And this graph here demonstrates that although there was a rapid rise in the number of scheduled video visits at Kaiser from those years 2015 to 2016, it essentially plateaued in 2017. The people who wanted to use it have already used it, and there's not new people coming into that system. And so Jay brings up the question then is, if we were to actually build a healthcare system around the ways that people culturally communicate in 2018, how would we structure a doctor-patient relationship? And so this involves three components. The first is that you'd have a simple single online place to get care, just as we have a single online place that people go to search or to watch movies or to shop. Then you would want to then build into this online service capabilities which are on par with in-person urgent care or office-based primary care practices. The way that Sherpa does this is approximately 8 steps. You log in, and these steps are screenshotted here on the online video, but you log in to a portal and you write a free text discussion of what your issue is. You can attach a file to this. Then your physician will send you back a questionnaire to complete. And this is a free text questionnaire, which is really crucial, meaning that you just answer in free text based on your symptoms, which you initially entered. The physician will review your results from the questionnaire, ask you perhaps to go get some imaging or to get some lab tests. Those tests are then, again, brought into this chat conversation thread. You can view it as well as your doctor can view it. And then ultimately, the hope would be that a medication would be given to you. You could take that medication, search inside the app for your nearby pharmacy, and send a prescription to the pharmacy. If you needed a specialist referral, this could be made through the application. You would go to the specialist. Afterwards, the specialist would send your own family physician back a report of what their assessment is. That gets scanned into the Sherpa system so that you can view the report as well. And then all of the summary of this interaction between you and Sherpa, or you and that physician, is summarized into a single page overview so that you can easily reference it. After this happens, the physician may follow up with you a few days or weeks later to ensure things are correct. And you've been able to essentially have this entire medical diagnosis, treatment, and care continuity without having to go in person to see a physician. Now, the really big psychology behind this entire system is the concept of synchronous versus asynchronous conversations. And we know, for instance, that that, or at least as Jay predicts, that the ability to have asynchronous digital communication may be as important as something such as, the printing press, because what it allows us to do is to move something which was a linear process, which was, seeing one patient at a time in a waiting room. And then if you took longer with one patient, everyone else behind them had to wait longer, to move into an asynchronous communication process where you can actually take an inbox, you can triage the inbox, and this becomes hyper efficient. Within synchronized processes, you then have to afterwards go and document that process afterwards, whereas in an asynchronous process, the communication actually is the documentation. And the other trouble with synchronous communication is it's very hard to standardize that oral conversation, whereas you can standardize an asynchronous history taking or communication plan much easier. The synchronous physician office appointment is only a tiny snapshot into an ongoing story, whereas when you're in asynchronous mode, you can check in with quick snippets over multiple care times, actually creating a higher touch experience overall. And then the other problem with the synchronous communication is that it assumes that what you're discussing is important enough that you have to call a meeting. It's kind of would be equivalent if you went to a company today and they said, whenever we need to discuss something in this company, don't send an email, you have to call a meeting. Whereas asynchronous communication allows the fact that most healthcare company communication doesn't require the intensity of an in-person visit. The other problem is that you can't really follow up easily when you have synchronous communication in healthcare, right? Whereas with you have asynchronous, it's very easy to send a follow-up to see how the patient is doing. And furthermore, when you know that you only have a 10-minute visit with the patient and you don't know when you'll see them again, you err on the side of being more aggressive in your practice style. Whereas in asynchronous communication, you can know that you'll have multiple interactions with the patient over a longer period of time, which allows you to watch the clinical course of a condition unfold, to be slightly more conservative in your practice style, and probably provide overall much better care. Of course, in synchronous communication inside the office, you're having to fuddle around with the EMR, trying to put into data there, to talking to the patient, trying to do a physical exam. Whereas in this asynchronous environment, the physicians are really able to focus on the communication, on triaging, messaging, and on responding. And so they actually are able to accomplish more total work. The billing mechanism, which was proposed for this type of a method of healthcare, is using the concept of something called an episode of care, which is the total duration it takes to resolve the issue. And this is partly how you would bill for something like this. So a UTI would probably take 3 days, a pneumonia 3 weeks, and a new breast lump 3 months. Each of these conditions has a condition onset. There's a certain amount of question gathering, prescription writing, imaging and diagnostics, and routine check-ins throughout this process. The question, of course, is, can you provide urgent care and primary care without having to have in-person office visits? And Jay proposes actually that 95% of all primary and urgent care, that's about 1,500 conditions, can be diagnosed virtually. The way that this virtual diagnosis happens is a combination of messaging and photos, and in 5% of their cases, they actually need to then also make a phone call to the patient. The big benefits to the patient are that they can access the service 24/7, that they get a response within 12 minutes of using the app. And they're finding more and more ways to bring by proxy to do diagnosis. For instance, for pneumonia, there's an app out there called ResApp. I don't know how valid it is, but it allegedly can, you cough into it, and then based on your vocal pattern, it can predict your risk of pneumonia. The other big problem with in-person healthcare is that the experience is actually really horrible for patients. As Jay pointed out, if you went and spent 10 minutes with someone professionally 2 to 3 times a year, and you couldn't have their email or their phone number, and you had to go through their assistant always to schedule a meeting, would you call that a meaningful relationship? It's kind of actually ridiculous or amazing that patients actually do, because outside of healthcare, you would not consider that a meaningful relationship. Similarly, when you go to see your physician quite often now, 80% of the time when you show up, they have you see one of their assistants. And again, do you think patients are actually impressed with this type of care? Whereas the alternative is if you can see the same physician every time you log into the app, you're going to have a much longer relationship with that person, and you'll actually have know them better. And similarly, if you move physical neighborhoods, you can retain the same physician which is seeing you, whereas when you have synchronous healthcare or in-person healthcare, if you move, you have to change physicians. Now, the other thing that Jay mentioned is there are times when you may meet someone, you may befriend them on Facebook or on Twitter, but you've never met in person, but it could feel that you actually have you actually know the person well. And in some ways, this is how people may interact with healthcare and their physicians in the future. Also trying to break down this 95% of problems which can be diagnosed remotely, we need to look at the fact that, most patients using healthcare don't use that much healthcare per year. 40% spend less than $200 a year, and then there's another 30% which spend somewhere between $200 and $1,000 a year. And so there's only a very small amount of power users who are actually using quite a lot of care and might have conditions which are of such level of intensity that they require in-person visits. Of course, change is hard. There's this great excerpt here from a book by Kristen Apokowitz discussing the evolution of modern medicine. And in it, she discusses the fact that another reason for the medical community's initial resistance to anesthesia was that it threatened to upset what had always been considered normal surgical procedures. Surgery was traditionally performed on a conscious patient, one who was able to communicate and express pain to his or her surgeon. Surgeons and doctors would use their patients' reactions, asking them questions or listening carefully to their wails or cries to help guide their surgeries. And so the biggest challenge which Jay is having, of course, with Sherpa is trying to get adoption and trying to show that in-person visits aren't required. But the reality is that healthcare, the doctor-patient relationship, is at its core a relationship of two humans communicating. And we've seen in the last 20 years dramatic ways in which we've changed how humans can communicate with each other. And most of the most successful companies have improved the ways which we communicate over distance. And so being able to do this in healthcare also means that there is the opportunity to have large wins in this space. Next presentation by Laura Jana, who's a pediatrician at Penn State, talking about how there's, of course, shift to prevention. And the shift to prevention and the shift to moving care upstream actually means that we're moving care, ultimately, if you keep tracking it back, more and more into pediatrics. And we know that by providing better health, nutrition, safe environments, early stimulation, and nurturing adults, you end up improving people's downstream effects for years in their life. And then the second part of her presentation discussed the fact of adverse childhood events, that this concept has been shown that it can have lasting events, adverse childhood events, on everything from health, from obesity, diabetes, depression, COPD, alcoholism, smoking, and even graduation rates, academic performance. And the number of adverse childhood events is proportionate to the number of these long-lasting effects. And so more work is being done to try to minimize adversity in the early years, with the hope that by putting energy into people's first years of life, that we're actually going to be able to reap benefits over the many coming decades in pretty much almost every physiologic test that they do when they're looking at the association of health problems and adverse childhood events, everything from depression to fetal health to drug use to liver disease to partner violence to smoking to COPD, as I mentioned. All are directly related to these ACE, or adverse childhood events. Walter Greenleaf is the next presentation. He's worked for many decades in the area of virtual reality, which he uses to incorporate both augmented reality, mixed reality, and his thought is that within the next 6 years, VR will be adopted by 70 million users. And this means that the adoption of VR will actually exceed the rate of the adoption of the iPhone or of the internet. And within 3 years, VR will likely be adopted by 30 million users. Now, obviously, it's going to enter into the public sector, but it's also going to be coming in through the enterprise sector. And the proposition is that healthcare will be the chosen enterprise sector which VR technologies develop. Now, of course, it's hard to imagine exactly how this is going to play out, because when he first got involved in VR, it was 1984, and at that time, computers were the size of refrigerators. But we know right now that there's at least 157 different emerging VR companies, specifically in the healthcare space, looking at least 20 different sectors. So we've talked a lot about things such as patient education, cognitive rehab, but PTSD, but VR is also being used for things such as physical rehab, addiction, speech therapy, ADHD, senior care, autism care, preventative health, pain and mood modulation, exercise, cognitive training, and of course, surgical training. There's an interesting concept of being able to use VR actually for diagnostic assessments, meaning that you could put a headset on someone or have them enter into a physical VR environment, and then based on that try to make neuropsychological assessments or assessments of daily living or OT-PT assessments, which is a very interesting idea on how cognitive assessments are going to change in the next several decades. And of course, virtual environments will continue to grow. Speech therapy, optical rehabilitation for strabismus, acute and chronic pain, and stroke and traumatic brain injuries. There's also benefits of being able to leverage mirror neurons, take people in their current state, digitize them into human avatars, and then manipulate the avatars to show patients how they may look in the future based off the decisions they make today, as far as changes for weight, for smoking, and such. And so VR can be very powerful in accelerating people's behavioral change. And then the other big things to realize about VR is that a lot of the apparatus, the technologies have shrunk, meaning that we don't need to hook up the system to as large of a computer anymore. But the other big advantage is that as 5G cellular comes in, we'll actually be able to probably stream in real time the bandwidth which is required to power these goggles, meaning that the processing power can be offloaded to the server side up in the cloud. There's some evidence also showing that VR can accelerate learning by twofold, because you can help enter into a flow state while learning a material, which expedites learning. Justin Berard is the next presentation, co-founder, or actually founder of Also VR, and he starts off with discussing a lot of the problems with current surgical training. The issue is that there's too much to learn. The amount keeps growing each year, and there's actually not enough time to learn it, because the amount of time available for learning continues to drop each year, meaning that with the introduction of the 8-hour work week, this has led to the loss of approximately 500 hands-on surgical cases, and that's about the equivalent to 1 year's worth of training. In addition, now that people spend up to 50% of their time on EHR-related and service tasks, there's, again, less time for actual surgical training, and we know that you need, direct surgical training time to actually produce competency. And some of the recent studies are showing that despite going through a full residency and fellowship program, up to 30% of the graduates in some of these studies couldn't operate independently when they completed training. And so Also VR is a virtual reality-based surgical training program with the hope that you can expedite learning skills. In addition, it has options to do collaborative learning so that you can learn with up to 10 people in the same physical virtual environment, even if they are joining into this virtual environment from other parts of the world. The performance scores that they did from their trials suggested that people performed 230% better when they were trained using this VR platform versus other traditional means of surgical training. There was a session near the end talking about radical interoperability. Of course, it was co-hosted by John Madison from Kaiser, CMIO there, discussing the fact that personal clouds for each patient are likely on the near future as the way to create radical interoperability. That there currently are startups looking on how you can lend your personal medical record to different companies and essentially receive a financial kickback or return for sharing of your data. John Nebaker from CMIO of Veterans Health Admin discussed the fact that patients do not care about interoperability. That interoperability is really a term of the computer experience, and what patients care about is seamless care. So he advocated that we use this term seamless care to explain the goals of how we want IT and tech and healthcare to operate. And of course, one of the problems with trying to make this happen is that a lot of the regulation and the perverse incentives structured around the regulation of health records, and trying to achieve compliance in those areas. Shannon Sarden from U.S. Health and Human Services talked about a lot of her work is trying to bring in talent into healthcare from fields outside of healthcare. Some sessions in leadership by Jason and Tori, Navy SEALs. Some sessions on the future of pharmacy. The interesting one was by Noah Kraft here, who's founder of Science 37. And what he essentially has created is a company which is a decentralized, distributed clinical trial platform built around patients. This is different than most clinical trials which are built around physicians and hospitals. The way that this works is that rather than partnering with individual hospitals and individual patients, you create a platform in which all the different groups can sign up to participate, clinics, research, telemedicine, patients, and they can all log into this platform to access patients for enrollment or to launch for clinical trials. So it's its own trial-oriented EMR, telemedicine platform. If you're running a clinical trial through their platform called NORA, the Network Oriented Research Assistant, you could send, for instance, nurses directly to a patient's home if you needed to do in-person follow-up, or you could follow up with them through telemedicine. If you needed to do blood work or lab work, you could push those requests directly to the patient. But essentially, you can run your entire clinical trial without having to use existing clinic or existing healthcare hospital infrastructure. This allows you to conduct trials over large geographic areas because enrollment now is much more easy. And they've integrated into this neural platform everything from patient engagement to recruitment to consent to trial workflows, telemedicine, remote monitoring, and audit trails. They are also bringing in far more new ways to recruit patients using social media, digital advertising, and different partnerships. And so again, many more diverse types of patients are able to enter into these trials than those typically found in large academic hospital settings. And they showed several different examples on how Genentech was able to do phase 3 clinical trials with rapid enrollment 21 times faster than other sites. Again, with showing results of 100% retention and enrollment scores far higher than other clinical sites trying to run these concurrent trials in their physical in-hospital locations. When you talk to patients about how they like the experience, they absolutely love it. It reduces all of the burden of being a patient in a clinical trial, which often involves having to go in for extra clinic appointments. And usually these appointments are longer than most normal clinical appointments. And so most clinical trials are actually like reasonably burdensome upon patients because they're built more around the hospital and the clinician. And so this platform is built around a way of providing better care to patients and providing that care in their own homes, and then being able to build on top of this network and leverage it for research projects. There's a final slide showing quite a number of pharmaceutical companies which are co-partnering with this Genentech-sponsored project, as well as other groups such as Google Ventures. Mimi Hu gave a presentation on United Neuroscience, discussing ways which we may be able to improve Alzheimer's treatment, specifically trying to figure out if there's a way to come up with a vaccination against Alzheimer's. Onno Faber gave a presentation on his life experience with the NF2 mutation, which causes benign tumors of the nervous system. But of course, the problem is that these tumors can impair function of those nerves, and brought up some interesting points that 1 in 10 people in the world have a rare disease, which actually means that hundreds of millions of people have rare diseases. There's about 70,000 rare diseases worldwide, but only 5% have treatment. So a lot of the discussion is trying to figure out how we can develop treatment pipelines for rare diseases, given the fact that rare diseases actually are not that rare. And finally, the Medi Awards at the end ended with 4 awards. First to Zito for their EEG contraption, second to CloudMedix for the AI bot talking with patients, to Alitia for their mouth lab device, which allows you to record temperature, blood pressure, pulse rate, ECG, heart rate, spirometry, cardiogenic oscillations, breathing patterns, respiratory patterns, and blood oxygen saturation, all by breathing on this simple handheld device. I look forward to seeing actually the price point on this, and want to get my hands on a demo version to see how good it is. And finally, Sequester, which is an EHR data aggregation platform. All right, we're very long presentation, but that was the summaries and high points from Exponential Medicine 2018, day 3, and tomorrow will be the last half day of the presentation. If you want, you can watch the original recording of the 12 hours of day 3 on the Exponential Medicine YouTube page, as well as all these slide images are available on the attached blog post on gregoryschmidt.ca.